So good afternoon, everyone. I think we can start. I think it's already 3:30. Most of you have been waiting. So welcome to this second discussion session, wherein we actually start the topics today. The previous class was just introduction and how to go about. And yesterday we could not arrange the class. So we are basically starting with today's session. So we'll be starting mainly on nutrition, mainly malnutrition, breast milk, its components, and what are the questions that can be asked in malnutrition, and some of the micronutrients also we will cover, and we'll try to solve as many MCQs as possible. Am I audible to everyone? Am I audible? Okay. So let's start with the first question. So what is true about cow's milk is all except. So first option is cow milk contains 80% whey protein and not casein. And cow milk has less carbohydrate than mother's milk, has more potassium and sodium than infant formula feeds, and has more protein than breast milk. So what is this question we are going to look into is, so how much is so first of all, you should know the concept of what is present in human milk and cow's milk. So definitely we all know the protein content in cow's milk is more, almost 3 times, 1.5 grams and 3 grams. So lactalbumin and casein. This lactalbumin is the whey protein, and whey protein is the lactalbumin in human milk, and this whey protein is 60% in human milk, whereas in cow's milk it is only 20%. Cow's milk major protein is casein, and sodium cow's milk is more, phosphorus cow's milk is more, calcium cow's milk is more, whereas in iron the human milk is more iron compared to cow's milk. So human milk has more casein, lactalbumin content, that is your whey protein, and human milk has more iron compared to cow's milk. So what are the other things that are? Calories is almost same, water content is almost same, and human milk has more carbohydrate, and fat percentage is almost same. So what is more in human milk is, so one is cow's carbohydrate is more, iron is more, and then your whey protein is more. Okay. So carbohydrate is more, your whey protein content is more, and the rest of the things like sodium, phosphorus, calcium are all more in cow's milk. So first option is like cow's milk contains 80% whey protein is wrong. Cow's milk contains only 20% whey protein and 80% casein. So first option is wrong. If we see other things, cow milk has less carbohydrate than human milk. That is true. That is, cow milk has less carbohydrate. That is 7.5 and 4.5, and has more sodium and potassium, and has more protein than breast milk. Okay. So these are the composition wherein just you have to brush up these numbers just before the exam. This can be asked as a match the following also, and also it can be asked as a elimination question like this. Okay. So coming to other, this was the last question that was asked in last INI set. So the height of the child, the height for age of the child is less than -2 standard deviation. And what is it due to? Whether it is due to no malnutrition, it cannot happen. There's no, if there is definitely malnutrition, whether it is acute malnutrition, whether it is chronic malnutrition, or whether it is recent infection. So both acute malnutrition and recent infection, both are almost same options only. You need not even read about it. So definitely it is no malnutrition is not an answer. So recent infection will definitely lead to acute malnutrition. So if there was anything else, so easily we can rule out these two options. So we can arrive at right answer, like the height for age will always represent a chronic malnutrition. Either if you know the answer, you can just write it as chronic malnutrition, or you can just eliminate the options. So usually some of the time both options will be dealing with the same answer, will lead to both clues will lead to the same answer. So that will be, you can easily eliminate such things. So recent infection will definitely lead to acute malnutrition. So we cannot have both answers. Okay. So coming to the third question. So we have a 4-year-old child who has severe wasting and has a voracious appetite and without pedal edema. So what kind of malnutrition is the child suffering with? Is it kwashiorkor? Is it marasmus? Is it both, or none of the above? So there is severe wasting is definitely baby has severe acute malnutrition. These two things, that is appetite and pedal edema, or a presence of appetite and absence of pedal edema, will give a clue that the baby has a marasmus. So if we see the differences between, kwashiorkor and marasmus, so marasmus usually seen in less than 1 year child, and if it is seen in first 3 years, and kwashiorkor usually seen between 1 to 5 years of age. However, they can occur at any age. Any age child can suffer from kwashiorkor or marasmus. Growth failure is severe in marasmus, whereas growth failure is not so severe in kwashiorkor, and also the presence of edema in the kwashiorkor will mark the weight retardation. Okay. And muscle wasting is remarkable in marasmus. Marasmus for muscle wasting. Okay. And subcutaneous fat loss is remarkable. The fat and muscle wasting is definitely marasmus. And psychomotor changes, like very apathic and very disinterested in surroundings and listless child, is your kwashiorkor child. And psychomotorly, if the baby is very alert, awake, and voracious appetite, it is marasmus. So marasmus child will be, there will be muscle wasting, marasmus for muscle wasting, and marasmus for fat wasting, and marasmus for good appetite, and the marasmus has no edema. Okay. So edema is an hallmark of your kwashiorkor. And apart from that, is appetite is very important. Appetite will be initially it will be very good in marasmus, and in later stages, the appetite may go when the child is severely wasted. And however, anorexic appetite, that is loss of appetite, is characteristic in kwashiorkor. And superimposed infections are very frequent in marasmic child, and not so frequent. It will occur in kwashiorkor also, but not so frequent as in marasmic child. So apart from that, I think you can answer only in maximum questions can be asked from this table only. Like we'll come up with the subsequent questions. So in our child, the baby has severe wasting and he has a good appetite, but there is no pedal edema. So it is marasmus. So para-amino benzoic acid of breast milk prevents what infection? So the answer is Plasmodium vivax, or if Plasmodium vivax is not given, it is malaria. So it is actually not the para-amino benzoic acid, presence of para-amino benzoic acid. It is the deficiency of para-amino benzoic acid that will prevent the multiplication of malarial parasite. It is not the presence of PABA. It is the deficiency of PABA in breast milk. That is what prevents the malaria. Okay. So all the time we may think that there is PABA which is present in the breast milk, and that will fight against malaria. It is not the situation. It is the low PABA which is present. And PABA helps in these multiplication of these malarial parasite in the blood. Whereas if the PABA level is only low in the breast milk, there will be low PABA in the infant or in the child. So that will prevent against malaria. So what are the other protective factors? Are secretory IgA. The secretory IgA will protect against respiratory and gastrointestinal infections. Macrophages, they also detect, engulf, and destroy pathogens. Any pathogens, irrespectively, it can do it. So lactoferrin, which is present, it is an essential growth factor, and it acts as a bacteriostatic agent, especially E. coli. And lysozyme acts against gram-positive bacteria. Bifidus factor, it will prevent colonization of Lactobacillus bifidus, and this will help in digestion. The bifidus factor may help in digestion. It is not a protective factor, it will help in digestion. And the other thing is complements and interferons, especially we know they protect against viruses. Low PABA, you remember this as low PABA, not like presence of PABA will prevent malaria. It is a low PABA level. And peroxidases will kill bacteria non-specifically. And these are the main responsible protective factors. Mainly what you should know is lactoferrin, which will prevent against E. coli, and your interferons against virus, and PABA against malaria. Okay. Coming to other breast milk questions, you may know the difference of foremilk and hindmilk. Foremilk is what comes initially for 5 to 10 minutes is your foremilk. It is mainly rich in watery and rich in protein, like carbohydrate, vitamins, minerals, and water. What is hindmilk is filled with fat. And what is the role of foremilk is, in addition to meeting requirements of nutrients, it satisfies infant's thirst. Whereas the hind milk is the main supplement of energy, and this is what is required for weight gain of the child. So fore milk is rich in protein, carbohydrate, and hind milk is rich in fat. So if we have to know apart from human milk and cow's milk, this is again the comparison between human milk, cow's milk, and buffalo milk. So out of the three, the highest protein is present in buffalo milk, and highest fat is also present in buffalo milk. So just because protein and fat are more, definitely blindly you can say the calorie content is also more. Whereas the water content is less because the fat and proteins are more. So the water content is less in cow's milk, buffalo's milk. Okay. So human milk has the highest lactose, and human milk also has protein of 1.2 and just 1/3 of protein as cow's milk. So what are the other things that are higher quantity in human milk as we discussed? One thing is whey protein, which is 60%. It is more in cow's milk. Other thing is iron is more in human milk than cow milk. So whey protein, iron, and carbohydrate. Okay. So these are the three things which are more in human milk compared to cow's milk. So coming to next question, this is again frequently asked. The decrease in weight for height indicates, so it is acute malnutrition. So height for age indicates a chronic malnutrition, and whereas weight for age, so weight for age is common to both acute and chronic malnutrition. Weight for age is common to both acute and chronic malnutrition. Weight for height, it is only acute malnutrition. Okay. And height for age is chronic malnutrition. So remember like that. So next question is WHO recommendation for antibiotic cover in a stabilized phase of treating a malnourished boy who is free of initial complications. So this is a severe acute malnutrition child. So what does the WHO guidelines say, that how do you treat a home-based treatment or a community-based treatment of severe acute malnutrition? What we have to give is oral amoxicillin for 5 days. Okay, so oral amoxicillin has to be given for 5 days. If there is admitted child who is with a complicated SAM, so we have to give is IV ampicillin plus gentamicin. IV ampicillin for 2 days followed by 5 days of oral amoxicillin, and gentamicin for 7 days. IV gentamicin for 7 days. So this is the difference. So for community based, that is without complications, we can just treat him in home with nutrition supplementation. So oral amoxicillin is what is prescribed. So we already we have seen this. So edema is the hallmark of kwashiorkor, and apathy or poor appetite is an hallmark of kwashiorkor, and apathy, that is listless or CNS, very apathetic child who is not interested in surroundings, who is very lethargic, and a presence of edema are the hallmarks of kwashiorkor. And also the skin manifestation. So skin manifestations are classically seen in kwashiorkor. Okay. So which of the following is not a correct sign of good attachment to baby to the breast? So what are the 4 signs of good attachment? So baby's mouth should be wide open. So next thing is lower areola more visible. So this is wrong. It is always the upper areola should be more visible, and baby's lower lip should be averted, and baby's chin should be touching the breast. So more easily you can get confused is one is between lower and upper, they can give a different answer. It is always lower lip averted and upper areola more visible. So upper areola and lower lip is averted. Okay, so only these 2 things you may get confused. Only give concentrate on these 2 things. Rest of the things is very open. If the baby's mouth is not wide open, how can the baby breastfeed? Okay, and the chin should touch the breast. And apart from this is they may give other options which are not at all suiting these 4 options. You can just eliminate the things easily. Only thing you concentrate is which lip should be averted and which your areola is more visible. So most often you will get confused with these 2 things. Okay. So what about kwashiorkor? So kwashiorkor is diagnosed in a growth retarded child. So what are the symptoms of kwashiorkor? Whether it is edema and mental changes, or hyperpigmentation and anemia, edema and hypopigmentation, and hepatomegaly and anemia. So what are the things you see in kwashiorkor, as I told? So the edema and mental changes are very classic of kwashiorkor. Though hepatomegaly may be seen, but it is not a requirement required for diagnosis of kwashiorkor. Though it is present in kwashiorkor child, the presence of hepatomegaly is not an absolute criteria to diagnose kwashiorkor. So in a breastfed infant, so why does there is less chances of enteric infections, fewer chances of enteric infections on immune system? So I think this question is not framed appropriately. What are the benefits of breastfeeding? So what are the benefits of breastfeeding to the newborn? So I have this chart from Nelson. So these are the conditions that which human milk may protective against for newborn. So definitely diarrhea, it will be prevented. Otitis media, urinary tract infection, necrotizing enterocolitis, and generalized sepsis, infantile body, and insulin-dependent diabetes. Definitely breastfed infants are less prone for type 1 and type 2 diabetes mellitus. Apart from that is celiac disease, Crohn's disease, and childhood cancer, lymphoma, leukemia, otitis media also, and also recurrent otitis media. And other protective. Other things are less hospitalization and less infant mortality. So you can go through once again, like diarrhea, we already know. Otitis media is already, we know it. What you can miss is whether lymphoma and leukemia. So definitely you have to remember these two things. There is protective effect of breast milk even on lymphoma and leukemia and other childhood cancers also, which if given an option, you may think, what will breast milk do about childhood cancer and lymphoma and leukemia? So always look for these rare options so that you don't mark it wrong. Okay. So apart from that, we always know that recurrent otitis media and otitis media and any other infections, mortality, all these things you may not go wrong. Apart from that, Crohn's disease and celiac disease. So what is not there is ulcerative colitis. They may give to confuse you in this. So ulcerative colitis is not there in this list. And rest of the things like any infection, if they give, you can add that it will prevent, breastfeeding will prevent the infection. Okay, this is a chart from directly from Nelson. So benefits of breast milk are, so I think as all the 4 should be given. So this option is marked wrong. So there is less allergy and less infection and better nutrition. So all the 3 are right answer. Okay. So while assessing the child of severe acute malnutrition, all are criteria except. So we know the 3 criteria, like weight for height is less than -3 standard deviation, edema and mid upper arm circumference less than 11.5 centimeter. So height for age is not a criteria for severe acute malnutrition, whereas height for age is a marker of chronic malnutrition. So breast milk is known to transmit which of the following infections? So answer is usually CMV. If it is active tuberculosis, then also it is an answer. But here generalized tuberculosis per se, if the mother is on and ATT for more than 2 weeks, you can definitely give breastfeed. So initial 2 weeks, that is active tuberculosis, wherein the mother is not on ATT, then it is a contraindication for breastfeeding. So just be careful with the option. CMV is definitely known to get transmitted. So this is not there. That was so compared to cow's milk, mother's milk has more. So already know carbohydrate is more. So lactose is the answer. So proteins are more in cow's milk. Fat is almost same. And vitamin D is definitely more in cow's milk. So lactose is more. Whey protein is more. And the third option is, what was the third option? Iron is more. Okay. Lactose is more. Iron is more. And whey protein is more in mother's milk compared to cow's milk. So which of the following is a best indicator for long-term nutritional status? So long-term nutritional status is anything that deals with chronic malnutrition. So definitely weight, height for age. So you already know mid-upper arm circumference is again marker of acute malnutrition. Height for age is chronic malnutrition, and weight for age is also acute malnutrition. Head circumference doesn't speak anything about malnutrition. Okay. So hind milk is richer in. So the answer is fat. Though fore milk is rich in, it is rich in protein, carbohydrate, minerals, and water. So fore milk is rich in carbohydrate, protein, and water, and hind milk is what is rich in fat and more in calories. Okay. So other questions are, WHO severe acute malnutrition is defined as. So first thing you should know is whether all things are weight for height only. So definitely all things are weight for height. So next thing is you have to search for right answer, which you already know it. Don't search for any other options. Weight for height, Z score is less than -3. So don't go to see other options at all. Unnecessarily you will get confused. So again, the same question. Breast milk is richer in dash when compared to cow's milk. It is definitely lactose. Okay. So all these other things are lesser in breast milk. So all of the following are seen in marasmus except. So marasmus, as I told, M for muscle wasting, M for fat loss, and M good appetite will be there. So weight loss is common to both and marked in marasmus. So hepatomegaly is a finding of kwashiorkor. Though it is not a diagnostic criteria, hepatomegaly, you always should know that hepatomegaly is present in kwashiorkor, whereas marasmus will have a shrunken liver. So the protective effect of breast milk are known to be associated with, actually the answer should be lysozyme also and also IgA antibodies. So what you can check is IgA antibodies is a suitable answer. For gut protection is mainly by IgA antibodies, whereas lysozyme in the breast milk gets absorbed and it provides systemic protection. So mast cells is nothing to do with immunity, and IgM antibodies are not transmitted via breast milk at all. So admission to NRC, that is Nutritional Rehabilitation Center for severe acute malnourished child between 6 months to 5 years, is all except. So when do you have to admit a child? One is definitely you have to know the criteria for basically they are asking what is the criteria for severe acute malnutrition. So weight for height is less than -3 standard deviation is definitely a definition. Mid upper arm circumference less than 11.5 is the part of definition. Weight less than 2 standard deviation for age, it is not in the part of definition and does not signify severe acute malnutrition also. And bilateral pedal edema is a definition, part of definition. So basically they are expecting you to know what is the definition of severe acute malnutrition. So this is the wrong answer, weight less than 2 standard deviation. So this is also not a right question currently. So fatty liver, why does fatty liver occur in kwashiorkor? So fatty liver is mainly because of reduced synthesis of lipoprotein carrier. So lipids which are present in the liver are not mobilized from liver to the periphery. So this is the main reason why fatty liver occurs in kwashiorkor. So nothing related to abnormal protein synthesis, or there is decreased protein substrates, nothing related to carbohydrates also. So mainly the lipoprotein carrier like ApoB or apolipoproteins which carry low density lipoproteins from liver to the periphery tissues is less in kwashiorkor. So that's why it results in accumulation of fat in the liver. So next question is, a 15-month-old child feeding on cow's milk with water with severe wasting and bilateral pedal edema presents with poor appetite. So basically they are describing a clinical condition of severe acute malnutrition. So either it is a kwashiorkor or marasmus. Again, the table will help you. So once you come with edema, it's almost sure that you are dealing with a kwashiorkor. And also other things will support like poor appetite, and severe wasting. So basically the answer is kwashiorkor. So Waterloo classification for nutrition in children takes into account. So what does Waterloo classification deals with this? What are the conditions that Waterloo classification? So we will brush up with some of the classifications. Mainly Waterloo and WHO, you have to remember, there are 2-3 classifications. So Waterloo has only 3 classifications. Waterloo based on weight for height, Waterloo's based on height for age, and also the Waterloo based on both weight for height and height for age. So the Waterloo has 3 classifications. Okay, so Waterloo weight for height is there, and Waterloo height for age is there, and another thing is Waterloo both weight for height and height for age. So one thing how simply you can remember is, so it has very high percentage. The percentages are, even though the name is Waterloo, the expected percentage, that is to call it as a normal child, is very high. For example, Waterloo weight for height is almost more than 90%. Expected height is considered to be normal. Whereas Waterloo height for age, if you want to consider it as normal, it is more than 98% is normal. So that's how I remember these things. So weight for age is 90, 90 to 80, 80 to 70, and less than 70. Here is more than almost 95% is normal. That is 95 to 90, 85 to 90, and almost very high cutoff. So that's how I remember. The names, though the name suggests it as low, the expected cutoffs that this keeps is very high. Very high cutoffs are in Waterloo. So Waterloo classification for malnutrition takes into account, so both it takes into account weight for height and height for age. There is separate classification like weight for height and height for age. So together is what is Waterloo, both weight for height and height for age, which includes both. Waterloo classification, both weight for height and height for age. Acute is both weight for height only is low, height is normal, and acute or chronic is weight for height is low and height for age is also low. So it accounts for both. So separately, when they call it as like both height classification and weight classification, separate is there. So one thing is combined is Waterloo. So both WHO classification and Waterloo are almost same. Okay. So WHO classification also has weight for height and height for age, and Waterloo also has weight for height and height for age. Remember like that. WW has common. So both have common. So this is the WHO classification of protein energy malnutrition. Though WHO classification cutoff is very lower compared to Waterloo classification, whereas Waterloo classification, he keeps it very high. So though the name is low, the cutoffs are very high in Waterloo classification. So that's how I remember things. So in PEM, the hypoglycemia is corrected by using 10% dextrose. Okay. And what are the other things? This is not a very good question. So what is the criteria for discharge in severe acute malnutrition? Next question is about what is the criteria? When can a severely malnourished child be safely discharged from hospital? So what is the criteria is? The child should attain height for age. That cannot happen overnight. You can easily eliminate this question. And the child reaches the ideal weight for height. This also will take around 6 months, 5 to 6 months. The rehabilitation time for a severe acute malnutrition is 6 months. He cannot reach an ideal weight over during treatment time. So what is important is the child loses edema and starts to gain weight. That is, good weight gain is more than 10 gram per kg per day. At least satisfactory weight gain is at least 5 gram per kg per day over 3 consecutive days is a good sign of weight gain. Okay. So other things are just distractors which he which you can easily eliminate. You cannot keep a child until he attains weight for his age. That will take around 5 to 6 months once you start rehabilitating malnourished child. So height attainment will take few years only. You cannot keep the child few years in hospital. And ideal weight for height also takes few years for the child who has been severely malnourished to reach. So either without reading also you can get such questions right also. Okay. So not seen in kwashiorkor is, so one apathy is definitely seen. Flaky pain dermatosis is a part of kwashiorkor, and increased transaminase levels can be seen. What is baggy pant appearances? Because of fat loss in the gluteal area. So there will be baggy pant appearance, which is a classical of marasmus. Okay. So fat loss and muscle loss will lead to baggy pant appearance in the gluteal area. So mostly death in PM is due to all of the following except. So this also you can blindly answer without even reading. Hypothermia can cause death. CCF can cause death. Worm infestation, definitely not an answer. And electrolyte imbalance like hypokalemia or hypomagnesemia or can cause death in a malnourished child. Okay. So already I told you, discharge criteria, minimum weight gain should be 5 gram per kg per day. A good adequate weight gain is more than 10 gram per kg per day. Okay. So false regarding complications of protein energy malnutrition is, so false is hypothermia can occur, septic shock can occur, electrolyte imbalance can occur, hyperglycemia does not occur, hypoglycemia. So how do you remember? Acute complication is SHIELD, SHIELD. So S for sugar is low, that is hypoglycemia. Sugar is low. H for hypokalemia. Okay. I for infections. EL is electrolytes, and D for dehydration. So these are the 5 complications of protein energy malnutrition or severe acute malnutrition during initial stabilization phase. So you have to look for 5 things. SHIELD. Okay. So flaky paint appearance is seen in kwashiorkor again. So Gomez classification, which is very old, it cannot be asked. It's not a very standard question to be asked. So we should know is what is Gomez classification. False about Gomez classification is, so it is based on hospital admitted children. You should know that it is Boston children. They only measured the height and weight of children who were admitted in Boston Children Hospital, and less than 90% is mild malnutrition. More than 90% is normal. And as I told you, it has a classification as a prognostic value. You can use only in hospitalized children, and it is based on it is not based on height retardation. It is based on weight retardation. Okay. So you can see is Gomez classification is weight for age, based on weight for age, not based on anything based on height. So flag sign again, it comes again and again, like seen in kwashiorkor. And one of the following is false regarding complications of protein energy malnutrition. Again, this is a repeat question. So usually it will be hyperglycemia will be the most commonly given option. You should not think of any other options. So again, difference between kwashiorkor and marasmus. So what is different? Which of the following is a feature of marasmus? So as we know, appetite is good. Fatty liver is seen in kwashiorkor, whereas in marasmus it is shrunken liver. Hypoalbuminemia is seen in kwashiorkor. Edema is also seen in kwashiorkor. So again, which is common to both acute and chronic malnutrition? Answer is weight for age. Weight for height is acute malnutrition, and mid upper arm circumference is also acute malnutrition, whereas height for age is chronic malnutrition. Height is chronic malnutrition. The child takes longer time to gain height compared to the weight. So that's how you remember. So in child with severe PEM, which of the following should not be included in the initial treatment? So initial treatment, as we all know, iron should not be given. Iron should be given only after the stabilization phase, because it leads to free radical generation and also can worsen infections in the child. So iron is given only after 7 days in a rehabilitation phase, not in the initial stabilization phase. You can give it in the rehabilitation phase. So initial protein requirement in a kwashiorkor child, you can just remember it as, so what basically they are asking you to remember is, what are the components of F75 and F100? So that is what they are asking. So initial protein requirement, what we are giving is F75. So F75 basically 100 gram has 0.9 gram of protein, 100 ml. So what we have to give is 130 ml per kg per day. So definitely it is more than 1. So definitely the right answer is 1 to 1.5. So you should know the difference between F75 and F100. So F75 and F100, you have to remember this. Calorie, we all know F75, it gives 70 kilocalories or 70 to 75 kilocalories. And F100 gives 100 kilocalories. Protein, 0.9 gram in 100 ml. Okay. So totally how much to give? Initially, it is 130 ml per kg per day. So it amounts to almost 1.3 grams, 1.3 to 1.2 grams. Okay. So F100 has almost three times, 0.9 to 2.9. Lactose, it is almost 3 times, or more than 3 times. And rest of the other things is osmolality. Osmolality is 333 milliosmoles in F75 and 419 milliosmoles in F100. Okay, the calories are more, the osmolality will be more. Everything is more. You can just remember it as like energy is also more, protein is also more, lactose is also more, potassium is also more. So definitely it is a higher dense diet. Just why we give a higher calorie and higher osmolality diet later on is if we give early, what happens is refeeding syndrome. So if we give a very high calorie diet in the initial days, what is we are will face a risk of refeeding syndrome, which we will discuss in next few questions. We will discuss it. So initial protein requirement in a kwashiorkor child is 1 to 1.5 grams. So what is not an essential criteria for kwashiorkor is, as we already told, hepatomegaly is not at all a diagnostic. It is not at all required for diagnosis of kwashiorkor. Whereas it is it is one of the clinical feature of kwashiorkor, but it is not diagnostic of kwashiorkor. What is required is apathy child, that is who is not interested, who is very lethargic and no appetite at all, and growth retardation and edema. Growth retardation, edema, apathy are the 3 diagnostic criteria for kwashiorkor. So acute complications of PEM all except something hyper will be given. So I look for that word hyper. So you can just easily look into it. So in kwashiorkor, the letter K, which you can keep at the end of designation, what does it signify is presence of edema. If the edema is present in a kwashiorkor child, you can add a letter K at the end of diagnosis. Okay. So what is false about marasmus? False about marasmus are all except. So what they're asking is what is true. Basically double negative, you have to ask which is true. So hypothermia, not the answer. Edema will not be present. Flaky paint is also kwashiorkor. So what they're asking is good appetite. So good appetite is a marker of marasmic child. So poor indicator to response during treatment of malnutrition includes. So how do you say that whether there is a primary failure of treatment during malnutrition or a secondary failure? So how you can remember is ApoE. That's what I used to remember. AP, that is ApoE protein, ApoE lipoprotein. That's what you study. AP for appetite. That is failure to gain appetite by day 4. Okay, so 2 things are in 4 and 2 things are in 10. That is how easily you can remember this. So 2 things are in 4 and 2 things are in 10. I think they have not given in this. I think it is in Guy. It is better given in Guy. So I'll just post you after the class. I'll just give 4. 2 things are in 4 and 2 things are in 10. That is failure to gain appetite is 4. And failure to start losing edema is also 4. Okay. So failure to gain appetite by day 4 and failure to start losing edema is also 4. 2 things are in 4. What are the two things by 10 is the presence of edema, that is disappearance of edema, and other thing is gain of weight at least 5 gram per kg per day. So they should be gain of weight at least 5 gram per kg per day. These two things are in 10. So edema should disappear by 10, and there should be gain of weight at least 5 gram per kg per day by day 10. So two things are in 4, two things are in 10, which I'll post in the group after the class. So don't worry, this is slightly a confusing question. So primary failure and secondary failure. So all of the following are observed in marasmus except, so already we know this, hepatomegaly. There will be muscle wasting. Low insulin levels are common to both marasmus and kwashiorkor. Extreme weakness are also common to both kwashiorkor and marasmus. Hepatomegaly is seen in kwashiorkor. Hepatomegaly is seen in kwashiorkor. It is not required for diagnostic criteria. Diagnostic criteria for kwashiorkor are apathy, poor appetite, and edema. Okay. So best indicator for growth monitoring in children is, it is not a single time measurement, that is weight or height or mid-arm circumference. So it is rate of increase in weight and height. This is a better marker of growth monitoring in children. So rest thing is chronic malnutrition. Again, height for age. Okay. So coming to, these are some of the routine repeated MCQs that can be asked. So some of the new things which you have to discuss, which you have to learn is, so what are the components of energy expenditure? So how do you calculate energy expenditure in a child? So what are the components of energy expenditure in children, and what are the components of energy expenditure in adult? So that's how you will be calculating how much the adult should eat and how much the adult calories are required. So adults, they have only 3 components. That is basal metabolic rate, that is the thermal effect of food, and also the energy that is required for physical activity. Thermal effect of food is how much energy is required to digest and absorb whatever food you eat. So these are the 3 components of energy expenditure in an adult. So what happens to the children is, apart from these 3 things, extra thing that happens in children is growth. So there should be addition of growth factor for a component of energy expenditure. So what is required is energy to support growth also should be present. So these are the 4 things that are present as components of energy expenditure in children. So what are the components of energy expenditure in children? One is basal metabolic rate, another one thermal effect of food. That is, thermal effect is how much energy is required to digest that food and absorb that food. Third one is how much energy is required for physical activity, day-to-day physical activity. Plus the children, one special characteristic of children is growth. So how much energy is required to support growth of the children. So all the 4 components are a part of energy expenditure in children. So whereas if they ask in adult, it is only 3 components. So additional energy intake and expenditure are required to support growth and development in children. Okay. So a breastfed infant of a mother who is a strict vegan diet may experience the deficiency of which of the following vitamins if the mother is not receiving supplements of the vitamin. So if the mother is strictly following vegetarian diet, so which deficiency the child will suffer from? Whether it is folate, biotin, B12, B6, K. So answer is B12. So plant source are not a good source of vitamin B12. So although they can be present, vitamin B12 can be present in dairy products and eggs. So vegans are not taking even the dairy products and eggs. So strictly vegan diet means they are not even eating the dairy products and eggs. So that's why these infants of these mothers are prone for vitamin B12 deficiency. So again, I match the following. Which vitamin does not match the clinical manifestation? So vitamin A, low vitamin A is marker of childhood mortality. Folate, anemia, we already know. Iron, anemia, we already know. Zinc plays a role in immune function. Iodine has a role in thyroid and other developmental disabilities, whereas dry skin is not a marker of this micronutrient. Okay. So iodine plays a role in goiter or hypothyroidism or mental abilities. So growth of mental abilities is what iodine is important. It's not related to any dry skin or anything. So again, all of the following are classical manifestation of kwashiorkor except edema, we already know. Rash in the sun exposed areas, achromotrichia, that is flag sign. Muscle weakness definitely will be there, and increased susceptibility to infection. So rash in the sun exposed area is not a characteristic of kwashiorkor. Rash can occur anywhere throughout the body. Rash in sun-exposed area is classically a marker of pellagra. So that is Cassell's necklace, what you see, dermatitis, dementia, and death. So the dermatitis in pellagra, that is niacin deficiency, is what you see rash in a sun-exposed area. Whereas rash in kwashiorkor can occur anywhere, even on the abdomen also, the rash can occur, or even in the back also the rash can occur. So again, which of the following statements regarding refeeding of a child with severe malnutrition is not true? So thiamine should be administered before starting feeding. That is true. Initial rehydration readily occurs via oral route. Yes, if the child is stable, you can start with oral route. Initial feedings should be 2 hours, every 2 hourly. That is right. Iron supplementation should be given in the first week of refeeding, and this is wrong. So iron supplementation should be given after 1 week to prevent infection and free radical generation. And empirical antibiotics are recommended before refeeding. So definitely they are prone for infection. So empirical antibiotics should be given. So initially there should be 8 to 12 feedings. That should be reduced to around 6 to 8 feedings after 24 hours. First 24 hours you have to give. The frequency should be given at least 12 feeds. That is 2 hours per day. 2 hours, every 2 hourly you have to give feeds. So iron is started only in the later phase. Okay. So what are the clinical features that are seen in overweight pediatric patients and which is not seen? That is except the clinical features are seen in overweight pediatric patients except. So what is not seen is acanthosis nigricans is definitely seen. Hypertension is seen, and snoring and poor sleep, and what is orthopedic complaints like hip and knee pain are definitely seen. So what is not seen is delayed puberty. So overweight and obesity children are prone for advanced pubertal age. Okay. Just a moment. So these are not the very important questions. So there are some of the questions which have been taken from Nelson pretest. So which of the following clinical scenarios increases the risk of vitamin A deficiency? So vitamin A deficiency, vegetarian diet, it is not the right answer. It is vegetarian diet like carrots and other green leafy vegetables and papaya, all these pigmented vegetables, they contain vitamin A. So it is not the right answer. Chronic intestinal disorders, definitely it will lead to fat malabsorption. Fat is required for diet. And zinc deficiency, definitely zinc deficiency will cause intestinal dysfunction and prevent vitamin A absorption. So all of the above is not a right answer. So both chronic intestinal disorders and zinc deficiency are a reason for vitamin A deficiency. So vegetables supply approximately 55% of vitamin A, and dietary and meat products supply around 30% of vitamin A. Okay. So both vegetarian and non-vegetarian diet are contributors to vitamin A deficiency. So which of the following statement is not true about vitamin A toxicity? So excess vitamin A in utero can cause congenital malformations. Definitely it is right. And it may present a pseudotumor cerebri. Is also true. That is, it may cause benign intracranial hypertension. An infant with preference to carrots and butternut squash may develop toxicity. We will come through it. It may cause fissures at the corner of mouth, pruritus and alopecia. Correct. It causes dryness of skin. Symptoms subside after rapidly withdrawing the source of vitamin. That is also definitely right. So preference of carrot. Carrot has carotenoids and not vitamin A per se. And excess consumption of carotenoids will only cause keratoderma. That is, or carotenemia. That is just yellowish discoloration of skin, and it is not equivalent to any like vitamin A toxicity. So other things of vitamin A toxicity are definitely in early, if the vitamin A is used, that is cis trans retinoic acid, which is used to treat acne, if they are used in first trimester, it will cause congenital malformations. And which of the following patients are at risk of thiamine deficiency? So exclusively breastfed infant and mother is well nourished? No. If the mother is well nourished, the infant will be protected because it will be transmitted from breast milk to the baby. Immigrant diet fed with vegetarian diet? No, vegetarian diet is a good source of thiamine. 3-year-old refugee whose dietary staple is only polished rice definitely is a risk factor. And 4-year-old American boy who eats only breakfast cereal. So cereals are also good source for thiamine. All the above is not the thing. So especially if we are eating only polished rice, it is also a risk factor for thiamine deficiency. So breastfed infants, if the mothers are deficient, if the mothers are not taking supplements, definitely it would have been a risk factor. But here, mother is well nourished. Well nourished mother is not a risk factor for thiamine deficiency. If the mother is also malnourished, okay, so then we can go with it. So this is also a very good question. Which statement about vitamin deficiencies is not true? So a patient with macrocytic anemia should be given a trial of folate replacement. I will come for it. Vegans have high risk for vitamin B12 deficiency. Definitely, we already know that vitamin B12, vegetarian diets are very poor source of vitamin B12. A patient with thiamine deficiency should be treated with supplementation of all B12, all B vitamins. Yes, if the associated B1 deficiency is there, all other vitamins also should be treated. Pyridoxine should be considered in infant with recurrent seizures. Definitely, pyridoxine dependent epilepsy is a condition wherein after your phenobarbital, phenytoin, and other first-line antiepileptics are not responding, they will definitely give a trial of pyridoxine to treat seizures. Pellagra may occur as a complication of anorexia nervosa. It is also a right answer. So the wrong answer is, in a case of macrocytic anemia, if we give only trial of folate, it will unmask the vitamin B12 deficiency. It will worsen the vitamin B12 deficiency. So what happens if you give a folate to a macrocytic anemia? So entire folate along with the whatever B12 the body has, it will be channelized to metabolism into the RBCs. So more vitamin B12 will go into RBCs. So it will precipitate your vitamin B12 deficiency, and the child or a patient can develop with B12 deficient symptoms. Okay. So a toddler who drinks pasteurized milk and avoids all kinds of fruits. So what is the risk the child will be suffering from? Rickets, no. Milk has a vitamin D. Beriberi, pellagra, peripheral neuropathy and anemia. No. If the child avoids taking fruits, as we already know, citrus fruits are the main source of vitamin C. So if the child doesn't take citrus fruits, he will suffer from scurvy. Okay. And rickets can be caused by, we know, nutritional vitamin deficiency. So apart from this is the other causes you also have to know, that is overuse of aluminum antacids, which will prevent vitamin D absorption. And also aluminum toxicity can also cause vitamin D deficiency. And prematurity is also a risk factor for rickets. And distal tubular acidosis can cause renal rickets. And so the answer is all of the above. So the rickets, other causes are, as we already know, rickets, main cause for rickets is vitamin D deficiency. Apart from that is calcium and phosphorus deficiency. The other minor causes you should also know is renal tubular acidosis, prematurity, and overuse of aluminum antacids. So again, match the following or an except question. Physical features of vitamin D deficiency rickets include all of the following except. So we know as craniotapes is a clinical feature. Enlargement of costochondral junction, that is rachitic rosary. Thickening of ankle and wrist, that is double malleolus. We already know. Large AF, bowing of legs, that is genu valgum, genu varum. And bitted spots are classical of vitamin A deficiency and not vitamin D deficiency. Another important question I wanted to discuss before I end. These are all. So one extra thing I wanted to teach is what are the definitions of estimated average requirement and RDA. So we already keep discussing what is RDA of vitamin A, what is RDA of vitamin A and vitamin D, how much vitamin to take daily. So what does it mean by RDA? What does it mean by estimated average requirement? So these are the two things which you have to know in definition. So if at all we are prescribing any vitamin, we should always prescribe RDA, that is recommended dietary allowance. Okay, so how much percentage of people will be covered if you give vitamin in RDA dose? That is what this question is about. So regarding nutritional requirement during childhood, all of the following are true except nutrition and growth during 3 to 6 years of child predict adult stature and some health outcomes. So we'll come to this. Major risk period for growth stunting is 4 to 24 months. This is definitely right. So major period of growth stunting in older adult age group, major period is between 4 to 24 months. This is when, if any insult occurs or malnutrition occurs, any infection occurs, there will be stunting occurring in the child. And estimated average requirement is the average daily nutrient intake that will meet the requirements of 50% population. So this is also a right option. And if you give RDA, RDA will cover 97% of the individuals in the population. So estimated average requirement, average, the word average itself will give a clue that it covers only 50% of population, and 97% of population will be covered if you give RDA. And what are the three components of energy expenditure? Basal metabolic rate, thermal effect of food, and energy for physical activity. Plus in pediatric age group, we already know it is energy for growth and development. So that those are the four components in pediatric age group. Any age group, these are the three components for energy expenditure. So this is one of the graph that shows if we are giving estimated average requirement. Suppose, for example, vitamin A estimated average requirement is 400 international units and RDA is 800 international units. Just imagine it's a number. So estimated average requirement, if you give 400 units, it will only be enough for only 50% of population. Rest 50% population will be deficient in vitamin A if you give the dose as required by estimated average requirement. Whereas if you give a dose of RDA, that is whatever prescribed by American Academy of Pediatrics or something, if we prescribe the dose in terms of RDA, we will be covering 97% of population. So only 3% of the population will be deficient with that vitamin. Okay. And what is upper limit is? Upper limit is the maximum dose that you can give safely without any side effects. So this is estimated average requirement. This only covers 50% of the people. Rest 50% will be deficient. If you give RDA, these only 3% will be deficient. So this is sufficient for any vitamin. After that, you continue to give. There will be no effect. And after this dose, if the upper limit is there, then the side effect starts. The side effect starts increasing if you give more vitamin A, any vitamin. So upper limit is above safe. That is a upper limit of safe dose without any side effects. RDA is what covers the 97% of population. Estimated average requirement is what covers the 50% of population. Okay. So another thing I wanted to teach is refeeding syndrome. So what happens if you give a high calorie diet during your rehabilitation phase? So what is the hallmark of refeeding syndrome? So what is the hallmark of refeeding syndrome? So all these three things are present in refeeding syndrome. What is the hallmark is hypophosphatemia. Okay. So hypophosphatemia, hypokalemia, and hypomagnesemia. All the three are characteristic features of refeeding syndrome. So what is the hallmark if they ask? It is hypophosphatemia. So hypokalemia can be present even in malnutrition also. Hypomagnesemia can be present in malnutrition child, whereas hypophosphatemia is the hallmark of refeeding syndrome. So this is the one of the clinical features and symptoms and etiology for refeeding syndrome. This is from Nelson. So hypophosphatemia. So hypophosphatemia. So hypophosphatemia, hypokalemia, hypomagnesemia. All the three are present in refeeding syndrome. And what is the hallmark is hypophosphatemia. Hypophosphatemia can cause cardiac illness, that is hypotension and decreased stroke volume. Respiratory, it can cause impaired diaphragmatic contractility. Neurologically, it can cause paresthesia, weakness, confusion, lethargy, areflexic paralysis, seizures, and coma. Hematologically, it can cause all the three lines can occur. Hemolysis can occur, WBC, it can cause glucoside dysfunction, thrombocytopenia also can cause. Hypokalemia, mainly cardiac arrhythmias, respiratory failure, neurologic weakness and paralysis, muscle rhabdomyolysis, and muscle necrosis can happen in hypokalemia. And hypomagnesemia, again, same as calcium, you can remember it as calcium, like tetany, seizures, altered mental status, and hypomagnesemia per se can cause refractory hypokalemia and hypocalcemia. So why does encephalopathy occur during refeeding syndrome? That is thalassemia, that is due to thiamine deficiency. And thiamine deficiency can cause encephalopathy, lactic acidosis. And sodium retention can cause fluid overload, pulmonary edema, and cardiac compromise. What you see is hyperglycemia, not hypoglycemia. Hypoglycemia is seen in protein energy malnutrition, whereas hyperglycemia is seen in your refeeding syndrome. If you give a high calorie diet during rehabilitation phase, so it will cause hypotension and hypercapnia and failure, respiratory failure, and other things is diabetic ketoacidosis can also occur, and they may be prone for infection. So there are some 3 questions. So the hallmark of refeeding syndrome is hypophosphatemia. Okay, all the 3 are present: hypophosphatemia, hypokalemia, and hypomagnesemia. The hallmark is hypophosphatemia. All the manifestation, major manifestation which we saw, that is hematological, cardiac, neurological, respiratory, our major manifestation is mainly because of hypophosphatemia. Okay, so encephalopathy in refeeding syndrome is mainly a result of, it is not due to hypophosphatemia, it is not due to hypokalemia, it is not due to hypomagnesemia or hyperglycemia, it is thiamine deficiency. So thiamine deficiency causes encephalopathy, lactic acidosis, and even death. And thrombocytopenia in refeeding syndrome is mainly a result of hypophosphatemia. So thrombocytopenia and also hemolysis and leukocyte dysfunction. All this, anything related to hematologic, if it is occurring in refeeding syndrome, is mainly because of your hypophosphatemia. So there are no other things like hypokalemia, hypomagnesemia. All these things will not cause any hematological condition. Only thing that can cause hematological condition in your refeeding syndrome is your hypophosphatemia. Okay, so these are the main things. Apart from that, that is frequently asked is what is the composition of standard ORS and reduced osmolarity ORS. Reduced osmolarity ORS is used in malnutrition. As we know, osmolarity is less, 300 and 311. So how do you remember is standard ORS is, what I used to remember is sodium chloride. So our table salt is sodium chloride. And apart from that, you have to only remember is potassium citrate. So sodium chloride is 90-80, potassium citrate is 20-10. So sodium chloride, potassium citrate. So these are the 2 things you remember in standard ORS. So NaCl you remember, that is 90-80. Potassium citrate is 20 and 10. So that's how you can remember standard ORS. Risomal you have to remember, and just before exam you can just brush up. So there's no way, no shortcut to remember this. Risomal, sodium is 45, and chloride is more, that is 70. Potassium is 40 and citrate is 7. Okay, this potassium is more compared to standard ORS, and sodium is half. Okay, potassium is double, sodium is half. Okay, these are the only 2 clues that you can remember in risomal. Apart from that, you have other minerals also present in risomal, that is magnesium and zinc and also copper. So 300 and 311 is the osmolality. So these questions have also come. It may come as match the following also. Standard ORS, sodium chloride, potassium citrate. Okay. So basically, these are the questions we have today. Anything like 5 minutes or 10 minutes it is left. Can we ask Yashasvini or someone to take up? Yashasvini, do you want to discuss about alcohol withdrawal? Can we have a discussion?
Hello. Can you hear me?
I will make you as a host to it, so that you can share it.
Okay.
You can share your screen now.
Okay.
You can share your screen now.
Okay.
Okay. Okay. You are sharing. You can just minimize this and go to your.
Okay. I think I'm audible, right? Am I audible?
Yes, you're audible. Go to word.
Okay. Good evening, friends. Today we'll discuss about alcohol withdrawal symptoms. To start with, this is the first question. A chronic alcoholic patient decides to get abstinent. After 3 days, he presents with confusion, disorientation, agitation, and visual hallucinations. What is the diagnosis? Is it delirium tremens, Wernicke's encephalopathy, Korsakoff psychosis, or alcohol withdrawal seizure? So, what do you think? So, the answer is delirium tremens. So, how did I say it is delirium tremens? For that, you should know what are the withdrawal symptoms. So, I have written a small table here. This hours will tell me how many hours before I have taken the last alcohol drink. So if it has 6 to 8 hours have passed after my last alcohol drink, so I'll present with tremors, nausea, and restlessness. If 12 to 24 hours have passed after the last alcohol drink, so I'll present with alcoholic hallucinosis. Usually it is auditory hallucinosis. If 24 to 48 hours have passed, before the last alcohol drink, I'll present with alcohol withdrawal seizures. If 48 to 72 hours have passed, then I'll present with delirium tremens. So what is this delirium tremens? What all I'll present if I say delirium tremens? So it will include visual hallucinations, disorientation to time, place, and person, and disorientation to consciousness, that is lack of consciousness. So delirium tremens is you will have visual hallucinations, disorientation, and lack of consciousness. So coming back to question, I have visual hallucinations, agitation is common, right? And there is confusion and disorientation is there. So, and they're telling it is 3 days. 3 days, again, coming back to table, it is 40, what did I say? 48 to 70, after 48 to 72 hours, I'll present with delirium tremens. So answer to this question, so because it is 3 days and visual hallucinations and disorientation, lack of, there's agitation, so the answer is delirium tremens. So next question, after 72 hours, so 72 hours of cessation of alcohol use, which of the following is seen in patients with alcohol dependence syndrome? Is it tremor, sweating? Is it alcoholic hallucinosis? Is it alcohol withdrawal or delirium tremens? In 72 hours, so it has to be delirium tremens. So if patients present with delirium tremens, how do you give benzodiazepines? Preferably chlordiazepine. If there is any liver damage, then you'll give Harrison pretest. So it seems to be a big question, but it is very simple.
Yashasvini, I think somebody else also is listening to your in another iPhone. It is active. So can you mute the iPhone mic?
Okay.
It is muted now. Yeah, it is muted.
Is it muted?
It is
okay, fine. So we were talking about delirium tremens, right? This table is important. So each of this is a potential question for us. Like 6 to 8 hours tremors, 12 to 24 hours alcoholic hallucinosis, 24 to 48 it is seizures, 48 to 72 it is delirium tremors, which is very important, delirium tremors. So how do I treat? I'll treat with benzodiazepines basically. So let us read this question. Okay, 42-year-old with alcoholic dependence. So we know he's alcoholic dependent. He's admitted for acute pancreatitis. Upon admission, he has an abdominal CT scan which shows edema without necrosis or hemorrhage. So there is no necrosis hemorrhage. He starts with dextrose, multivitamins, thiamine, pain control, all that. He typically drinks 24 beers daily. So we know he's chronic alcoholic dependent. So 48 hours. So this is important. How many hours has happened? So 48 hours after admission, you are called because the patient is febrile, so fever, and he's very combative with the nursing staff. His vital signs demonstrate a heart rate of, so there is tachycardia, there is hypertension, there is tachypnea, temperature is 38, and oxygen saturation has fallen to 94. And he's agitated, diaphoretic, pacing in his room. He's oriented to person only. His neurologic examination appears non-focal. Okay, although he does not cooperate, he is tremulous, so tremors are present. What is the next step in the management of this patient? Okay, so we already know he's alcoholic dependent. You have admitted the patient, and how many hours have passed? 48 hours have passed. So after 48 to 72 hours, I told he will present with delirium tremens, but this patient is so agitated, he has tachypnea and all this. So this is a case of severe delirium tremors. Okay, tremens. So what did I say? How will I treat with highlighted delirium tremens, I'll give benzodiazepines. So now come to the options. Administer a bolus of 1 liter of normal saline and thiamine 100 mg. So thiamine is already given for this patient, so I'll not consider this option. Second, administer diazepam 10 to 20 mg IV, followed by bolus doses of 5 to 10 mg as needed, and is calm but able to be aroused. Okay, I'll consider since it is a benzodiazepine and patient is very agitated. So then perform an emergency head CT. Okay, why I will not do CT is because in the question, if you see, they're telling upon neurological examination, non-focal deficits are seen. So CT is not a best option here for this patient. Perform 2 peripheral blood cultures. Okay, I can consider because fever is there. And begin treatment at imipenem 1 gram IV every 8 hours. Higher antibiotic need not be because this patient, since if you see in the question, he shows edema without necrosis and hemorrhage of the pancreas. So it might not be due to infection, so need antibiotic is not that necessary. Place the patient in 4-point restraints and treat with haloperidol 5 mg IV. 1 second. Okay, this restraints are how you tie a patient, right? So that is what they're telling. This patient is already agitated, this might even harm him. So the best option will be a diazepam, giving diazepam, which I already said, which is a treatment of option. Here, since he's very agitated, I'm giving IV, otherwise you will give him oral. So this is about delirium tremens. Then next question, a chronic alcoholic patient suddenly withdrew his alcoholic consumption. Later, he developed tremors, global confusion, ataxia, and other associated symptoms. Which among the following is the most appropriate treatment? So what is he presenting with? Tremors, global confusion, ataxia, and other associated symptoms. So methylcobalamin, IV thiamine, methylmalonyl, or benzodiazepines. The answer here is IV thiamine. Why IV thiamine? What is this syndrome? Presenting with global confusion, ataxia, Wernicke's encephalopathy, which is an acute presentation where there is thiamine deficiency. So the cause for Wernicke's encephalopathy is thiamine deficiency, which is usually seen in chronic alcoholics. So what is a triad of Wernicke's encephalopathy? If you see any of these three or these three in your, it is Wernicke's encephalopathy, the mnemonic being Goa. Sorry. So the mnemonic being Goa. So G for global confusion, O for ophthalmoplegia, A for ataxia. Ophthalmoplegia, usually 6th cranial nerve is involved, 3, 4, 6 are involved. So, and is the mnemonic. And treatment, I said no. Since there is thiamine deficiency, let us treat with thiamine. So the recovery of the symptoms will be in the order of first your ophthalmoplegia will recover, then confusion. Which stands for ataxia here. Mnemonic is LCA. L is for learning difficulties, C is for confabulations, and A is for amnesia, which is your anterograde amnesia. So this triad will give you Korsakoff syndrome. Again, long-term supplementation of vitamin B1 orally can be given. So in any question, if you see this, then it is Korsakoff syndrome. If you see global confusion, ophthalmoplegia, ataxia is there, means it is Wernicke's encephalopathy. It is mainly due to deficiency of thiamine. Then following is this question, following is a feature of Korsakoff syndrome. Anterograde amnesia, memory loss, confusion, ophthalmoplegia and ataxia, loss of identity, memory and intact personality, impairment of implicit memory and immediate recall. So what do you think is a feature of Korsakoff psychosis? What did I say? Anterograde amnesia with recent memory loss. If it is confusion, ophthalmoplegia and ataxia, what is this? Is your Wernicke's encephalopathy. So difference between these two is important. So you might get confused. Here A for amnesia, here this is A for ataxia. So that is important. And next question. A 8-year-old woman is recovering from alcohol dependence and requests medication to help prevent relapse. So now you know there's a how long you can't give a benzodiazepines every time, right? So you have to prevent the relapse. Any acute presentation you will treat, but to prevent relapse, we have these things to prevent relapse. So let me read the question. She has a medical history of stroke occurring during a hypertensive crisis. Which of the following medications could be considered? Is it acamprosate, disulfiram, naltrexone, or both A and C, or all of the above? What do you think? Majority of you might choose all of the above, but here the patient is also presenting with stroke, hypertensive crisis is there. So the answer here will become A and C, acamprosate and naltrexone. So to talk about this, so to prevent the relapse, we have two things. One is aversive agents can be given or anti-craving agents can be given. So in aversive agents, I have disulfiram. In anti-craving agents, I have naltrexone and acamprosate. Along with this, I have to give cognitive behavioral therapy, which is very important. In any case of psychiatric illness, pharmacotherapy is there and there is psychotherapy also, which includes your CBT and ERT and all that. So behavioral therapy is important. So I'll read out the answer for this. So in individuals recovering from alcoholism, several medications may have a modest benefit in increasing abstinence rates. The two medications with best risk-benefit ratio are acamprosate and naltrexone. So how does acamprosate act? It will inhibit NMDA receptors. It will decrease symptoms of prolonged alcohol withdrawal. So they're telling acamprosate and naltrexone are best risk-benefit ratio are present. So we will usually give this. So naltrexone is an opioid antagonist that can be administered orally or as a monthly injection, and it will decrease the pleasurable feelings associated with alcohol consumption. Disulfiram can be used. It is an aldehyde dehydrogenase inhibitor, and in this patient we are not using because see, the primary mechanism by which it acts is to create negative, they're talking about disulfiram. The primary mechanism by which it acts is to create negative effects of vomiting and autonomic nervous system hyperactivity when alcohol is consumed. We know, right, it will inhibit one of the enzyme which is involved in the metabolism alcohol. So it will create all this hyperactivity of ANS and vomiting. That is how it acts. So, but in this patient, since I have history of stroke and hypertensive crisis, I will not consider disulfiram. So better to go with A and C. So this is about prevent of relapse of alcoholism. This is about chronic alcoholism can lead to Wernicke's and Korsakoff syndrome. If both present, it is called Wernicke-Korsakoff syndrome. So this you should know, LCA and GOA. And what you are treat? I'll treat with thiamine. And along with that, you should know about delirium tremens, how I treat it, and each of this you should know. After how many hours, what I'll present with. This is a short topic. This question is asked last year in NEET and 2 of the INISET papers. So every year we get a question from this. So let us not make mistake in this topic. That is what I feel. If you know correctly what happens, then it is fine.
Thank you, Yashu, for wonderfully. And I think Subhramanya is ready to just discuss briefly on Porphyria. Subhramanya, you are there?
Yes, sir.
Okay, I will make you wait. Just claim. Yashasvini, can you make me as host by clicking in it?
Okay.
Are you able to do?
Yeah.
Shall I share that for you? Document.
Yes, sir. Okay.
Are you able to do it or not? Bartilva?
ಇಲ್ಲ ಬರ್ತಿಲ್ಲ.
Okay, I will share it for you. You just have to speak.
Okay.
Wait a minute.
is pyridoxal phosphate, and then ALA dehydratase will act, resulting in formation of porphobilinogen. Porphobilinogen is acted by HMB synthase, which is also known as PBG deaminase or uroporphyrinogen 1 synthase, resulting in formation of hydroxymethylbilane. This hydroxymethylbilane is also can be called as uroporphyrinogen 1 because it gets converted non-enzymatically by UCP1 synthase, uroporphyrinogen 1 synthase into uroporphyrinogen. However, the main reaction will be the hydroxymethylbilane will get converted into uroporphyrinogen 3, subsequently coproporphyrinogen 3 and protoporphyrinogen 3, later protoporphyrinogen 9, and lastly resulting in eventually formation of heme. So you can remember here that the pathway will be like U, C, and P, eventually leading to formation of heme. Totally, there are 8 groups of porphyria, out of which 4 are autosomal dominant, and 4 are and other 4 are rest are non-dominant. Sir, next page.
This one? Next page.
Next page. Next page.
Okay.
Out of 8 porphyrias, 4 are autosomal dominant and rest are autosomal recessive. Out of autosomal recessive, 1 is X-linked recessive, that is ALA synthase is the X-linked recessive, leading to X-linked protoporphyria, and the rest 3 are autosomal recessive. They are erythropoietic protoporphyria, congenital erythropoietic porphyria, and ALA dehydratase deficiency porphyria. Among all the reactions which we come across in biochemistry, there are mainly 3 reactions which take place in both cytoplasm and mitochondria. One of them is one of the 3 is heme pathway, and the other 2 are urea cycle and gluconeogenesis. In this, the heme pathway, you can see that the first step, that is the rate limiting step, occurs in mitochondria, and the last 3 steps also occurs in mitochondria. Apart from this, all the other steps takes place in cytoplasm. Okay. Next, I will discuss about lead poisoning. In the lead poisoning, usually the heme synthesis pathway is affected. The main enzymes affected are ALA dehydratase and ferrochelatase. So as these enzymes are inhibited by lead, due to this negative feedback pathway, ALA synthase enzyme will be increased. And usually in the question, there will be history of patient living in old home or eating paint like pica. The history of pica may be given in the patient, and in clinical features, basophilic stippling will be given. Apart from that, there will be pallor, anemia, encephalopathy, abdominal colic, constipation, encephalopathy, foot drop, and saturnine gout. You can remember as ABCDEFG. Okay, then next page. Yes. Then you look at the total 8 porphyrias. They can be divided into neurovisceral porphyria and cutaneous porphyrias. Usually, the neurovisceral porphyrias are those porphyrias which are seen in the conditions where the enzyme deficiencies are involved in the early pathways. whereas cutaneous porphyrias are those porphyrias which are involved in the enzyme deficiency of the later pathways. Okay, and you remember that hereditary coproporphyria, I have written it as HCP, and variegate porphyria, you will see manifestations of both neurovisceral symptoms and cutaneous symptoms. Apart from this, you can remember the porphyrias with presence with only cutaneous symptoms are usually involves RBCs in it, that is erythropoietic protoporphyria, congenital erythropoietic porphyria, and porphyria cutanea tarda. Along with that, X-linked protoporphyria also presents with cutaneous symptoms only. Among these cutaneous symptoms, erythropoietic protoporphyria and X-linked protoporphyria presents with non-blistering lesions. Other porphyrias present with blistering lesions and photosensitivity. Sir, next page. Acute intermittent porphyria is the most common porphyria, and the patient usually presents with unexplained abdominal crisis. There will be increased porphobilinogen in the urine. There will be nervous system dysfunctions, and hyponatremia will be seen in these patients. And variegate porphyria is the only porphyria where you'll see unique fluorescence peak. And the other tests used are Ehrlich test, Watson-Schwartz test, and Soret band at 400 nanometer can be seen in these porphyrias. Lastly, congenital erythropoietic porphyria. Congenital erythropoietic porphyria is also called as Gunther's disease. It is autosomal recessive, and it is characterized by uroporphyrogen 3 synthase deficiency. It is the as it manifests early in the early stages at the onset of birth. It is the porphyria associated with hemolytic anemia and cutaneous lesions. So it is the condition which presents from birth, and it is usually associated with non-immune hydrops fetalis. Okay. Okay, this is in brief about porphyria. Thank you, sir.
So do you get pediatric questions or adult questions in porphyria? Like, what is the main question asked? That is in, what are the questions that are asked in exam about porphyria? So what questions you may expect? They can ask like which enzyme is deficient, or what is the diagnosis, and what is the diagnostic test you want to do. So questions. So these are the three that can be asked in you. What they may give a clinical scenario, and they may ask you to identify what is the diagnosis. And second thing, they may give a clinical scenario and tell you what enzyme is deficient in this condition, or they may give a clinical scenario and tell what test you do to arrive at the diagnosis. So these are the three ways they can form questions.
And based on the clinical symptoms, first we should know whether they are asking about they are talking about cutaneous symptoms or neurovisceral symptoms. Okay. And on the basis of that, we can rule out the option and come to a diagnosis.
Okay. Okay. Good. We can just discuss some MCQs. You can post some MCQs in the group also later. Whenever you find out, you can post some. Next class, those MCQs. So as and when you any MCQs, you just post in. There should not be any MCQ left at all, even in adult or even Harrison pretest or in Nelson pretest. I will also, if I get any MCQs, I will also search and post it. You can post from your respective classes also. MCQs you got. Okay.
Okay, sir.